Moving on to the next session, can I ask Dr. Balamurugan, Dr. C. Muralidharan, and Dr. Chellamariappan to come and chair the next session, please.
Thanks for the opportunity from the Track 2024 Scientific Committee, and already we are running short of time, so I didn't want to take much time. And the first speaker of this session will be Dr. Periyandava. Can I have the slides of Periyandava, please, who talk on diabetes and cancer, consensus and controversies. Introductory slide, do you have? No, I will introduce Periyandava because Periyandava does not require any introduction. Periyandava was our alumni from MMC Diabetology, and he was a professor of diabetology and biochemistry was in Madras Medical. Recently, he has just attained the superannuation, and he's got a academic and very much, he's got a good organizing skills and very, very friendly and helping. Over to you, Dr. Periyandava, to talk on diabetes and cancer.
Thank you, respected chairpersons. It's a great pleasure in delivering this lecture on diabetes, cancer, and consensus and controversies. I thank the scientific committee and headed by Dr. Paneerselvam and Dr. Chandrasekhar. And my flow of talk will go like this. First, prevalence, pathophysiology, diabetes and its management producing cancer, cancer and its management producing diabetes, and conclusion talks. And we all agree the incidence of diabetes is going up and up, and in same way the incidence of cancer also is going up and up. It's a real world evidence that every hospital is flooded with cancer patients, and every family 1 or 2 cancer patients are there, and 20 to 30% of elevated breast and colorectal cancer have been identified in the recent studies, and 97% elevated risk of intrahepatic cholangiocarcinoma and endometrial cancer are also found out in the recent studies. And one sad thing about the diabetes is diabetics are more likely to develop cancer when compared to non-diabetic population, and diabetes was associated with greater cancer-specific mortality when compared to non-diabetic counterparts. And I have, because it's a controversial topic, and some drugs, the contradicting reports are coming, some drugs implicated with cancer, and the patients are getting annoyed when they are using the drug. So I took much effort in selecting my slides, and I have referred 6 topics, 6 articles. And 1 from endocrine article, 2 from diabetes, and 2 from cancer oncology articles. And this one is from Medical Clinics of North America, very old article published in 1956. Even in 1956, it clearly indicated IGT in those days. Impaired glucose tolerance is usually found in cancer patients, and the mechanisms linking these cancer and diabetes are speculative. And of course, this is a oncology article, and this is also a oncology, European Journal of Oncology, and this is a diabetes care article, this is an endocrine article, and from this article I have taken my slides. And coming to the pathophysiology, it's a little complicated, but the main thing is insulin resistance. So we, in 3 decades back, this was the initial Revan syndrome definition. So insulin resistance pivotal role, and hypertension, diabetes, dyslipidemia, obesities, if not treated, and it lead on to atherosclerosis. And modern understandings, it moved on to the cellular events. So insulin resistance producing obesity, diabetes, in addition to inflammatory markers like popular thing is interleukin 6 and this C-reactive protein. And oxidative stress, this has been highlighted in many recent researches, the reactive oxidation species, and of late recently the mitochondrial dysfunction and impaired ATP production, and ultimately lead on to cardiovascular events as well as this cancer incidence. And of late the recent developments in the field of renin-angiotensin system, as well as the advanced glycation end products and endoplasmic reticulum stress, everything is a recent development in the precipitation of cancer. And this is taken from very old book, the mechanism of insulin action, wherein the insulin receptor, which is present insulin receptor, and once the insulin sits in the alpha subunit of receptor and the beta subunit, through intracellular events, the various through inositol phosphate 3 kinase pathway 1 and the RAS pathway through MEK pathway, one more gene expression. This was the older understanding, and nowadays the recent advances in the cellular function, intracellular function is much complicated, and to simplify it, the same previous thing. So one side, the cell cycle is mediated by this intracellular action of insulin, and the other extreme, protein synthesis and cell growth. These two are altered when there is insulin resistance, when there is impaired the insulin receptor function. And simplifying all these three intracellular events, the metabolic syndrome, how metabolic syndrome lead on to cancer. So this is the pathway. The excess weight adiposity lead on to increased free fatty acid elaboration and tumor necrosis factor alpha, and increased resistin and diminished antibody. You all know adiponectin has a beneficial effect. In obesity it will be reduced, and insulin resistance lead on to hyperinsulinemia. Hyperinsulinemia produces more activation of these insulin receptors, and the target cells produce reduced apoptosis and increased cellular proliferation, and at last that tumor development is imminent. So, and I should mention about this IGF, that insulin and insulin growth factor system. The IGF system contains three components. So one is insulin receptor, one is IGF, insulin-like growth factor 2, and the third one is insulin-like growth factor 1. So among these, insulin-like growth factor 2 is most worse when you look into the oncogenic angle, and it's a main thing which produces the mitogenic signaling. And coming to the IGF-2, it produces overexpression of IGF-2 is also associated with cancer development, and the loss of imprinting and overexpression of IGF-2 is observed in many tumors. And the insulin receptor and the IGF receptors, and this already I have mentioned about this intracellular action, and ultimately it lead on to this increased T cell production and increased gene expression and diminished apoptosis and the tumor genesis. And of course, I should mention about the other risk factors, the increased leptin and increased interleukin, as I mentioned earlier, the inflammatory markers, interleukin 6, tumor necrosis factor alpha, and the nuclear factor kappa light chain enhancer, and hypoxia inducible factor 1 alpha, HIF 1 alpha, and cyclooxygenase 2, the COX2, and macrophage migration inhibition factor, MIF, all has been implicated in the development of cancer. Of course, this is a very common thing which we used many more decades. Age, gender, more often in men, race and ethnicity, African Americans and non-Hispanic whites are more likely to develop cancer. Obesity, inactivity, smoking, alcohol, everything has been attributed, lead on to cancer. And of course, recently it has been found out the increased fat cell mass has been also implicated in the development of cancer. And of course, of late recently, the more incidence of breast cancer is coming up, and the reason they have postulated is increased aromatase expression increases bioavailable estrogen levels in the circulation, and which increases IGF-1 and which reduces the SHBG and increases estrogen levels. And of course, the alteration in leptin levels, insulin and TNF-alpha, interleukin 6, all known to stimulate aromatase. Aromatase is one thing which is implicated in the development of breast cancer, and it has been found that estrogen directly stimulates MAPK pathway, of which we have discussed some few minutes back, and it leads on to cell proliferation and tumor growth. And coming to the transcription factor, the peroxisome proliferator activator receptor, the ubiquitously expressed PPR gamma induces fatty acid oxidation and differentiation of keratinocytes. Activated PPR gamma also is anti-tumorogenic. And coming to this, the diabetes and cancer, a twisted bond. It is, this paper has been published recently in May 24. Several genes have been identified that increase the susceptibility both to type 2 diabetes and cancer development. That is TCF7L2 and CDKN2AB, AKT2 and PPARG like this. So many genetic level studies have been produced. But then this is one mechanism of action, how diabetic patients get more cancer. And usually you look at this, this pink color cell. So once in a normal person, if any tumor cell develops, so two things, one, macrophages will come and engulf and it will destroy it. And other, when there is any possible mutation comes, the DNA repair mechanism will take place, come to the limelight, and they will clear that, prevent that cancer formation. But in diabetes, so advanced glycation end products and glycation of fibrous ECM proteins, hyaluronic acid, fibration of the glycosylation of laminin, collagen, everything will lead on to it will prevent that macrophage engulfing, and tumor cells grow unabatedly. And this hyperglycemia, as a result of hyperglycemia, major DNA repair mechanism pathways are blunted, like base excision repair, nucleotide excision repair, mismatch repair, everything. So in hyperglycemia, the cancer cells will grow very fast. And patients with chronic pancreatitis, this pathophysiology of cancer in relation to hyperglycemia. So patients who had a history of chronic pancreatitis, the most common cause of type 3C diabetes mellitus have a 10 to 20-fold increased risk of pancreatic cancer. And in patients with both chronic pancreatitis and diabetes mellitus, this risk is increased 33-fold. And type 3C diabetes mellitus resulting from pancreatic cancer appears to be connected to the chemicals that cancer releases. And some studies showed that the use of anti-diabetic drugs like incretin-based therapies and DPP4 inhibitors could serve as a risk factors for pancreatic cancer. And this one more controversy, some 10 years back, pioglitazone producing bladder cancer. This was a controversy. Nowadays, recent 1 year back or 2 years back, semaglutide is implicated in the thyroid cancer, everything. But everything has been, in subsequent studies, has been proved to be wrong. And in fact, pioglitazone prevents cancer, and these incretin-based therapies are little safe like that. So various contradicting studies are coming in. However, the beneficial role of these chemical agents overweighs their detrimental actions in cancer management. And now this is a very important thing. I have taken the next few slides from this article, drugs producing cancer. This is what limelight in every patient is asking whether this drug can produce cancer like that. So, and this is a, of the 10,543 citations uniquely identified, this is a pooled data. 10,540 citations uniquely identified from databases, 323 studies have been shortlisted, and 93 studies were selected for inclusion. And this for every drug, the implication, whether it's relative, the causative factors, and the impact of the drug usage and the development of cancer, like this. So first thing is lung cancer and breast cancer, colorectal cancer, and liver cancer. So like this, so various, it is an elaborate study, and its study showed the evidence of increased and decreased risk of cancer was found. For example, biguanide was associated with a moderately decreased risk of colorectal cancer and a considerably lower risk of liver cancer. Thiazolidine use was found to be moderately reduced the risk of breast, lung, and liver cancer. Conversely, the use of insulin secretagogue was associated with moderately elevated risk of pancreatic cancer. And the opposing association with the different cancer sites within the medication class was also evident. And in this context, the insulin was associated with the high risk of liver and pancreatic cancer, but insulin-taking patients has lower risk of breast and prostate cancers. So these are the mechanism of action of metformin in tumor protection through this mTOR pathway. And this is a mechanism of role of these glitazones in preventing cancer. So 10 years back, glitazone have been implicated in cancer, bladder cancer. Now it has been found that the glitazones, by reducing insulin resistance, that is an indirect way of telling. So it's protective. And coming to the next agenda of my talk, whether cancer treatment produces diabetes. So first thing is chemotherapy. Most chemotherapeutic agents result in cell cycle or cellular DNA damage and thus leading to apoptosis disproportionately in rapidly dividing cells. A number of studies reported that patients who received chemotherapy such as paclitaxel, UFT, that is uracil, tegafar, uracil, and interferon alpha has developed fulminant type 1 diabetes. And of course, glucocorticoids are used in many blood cancers, and glucocorticoids used to reduce cancer pain, to reduce chemotherapy-induced side effects. They are used extensively during every chemo cycle to treat cancer-related cachexia and treatment of inflammatory complications, chemotherapy. These glucocorticoids are used. And we all know once you give steroids, the hyperglycemia goes haywire. And even the targeted therapy like anti-insulin like growth factor, IGF, IR, and the mTOR inhibitors have been notable to produce this hyperglycemia. And the immunotherapy like anti-PD-1 antibodies, anti-PD-L1 antibodies, they all have been implicated in the development of diabetes. And association between diabetes mellitus and cancers have been, the genetic factors have been identified, which I have already mentioned, some of the genes, and here also some of the genes, say MAD, RS1103914, MTNR1, like this, various genes have been identified. And one final few slides, the insulin analogs and diabetes. So human insulin, aspart, lispro, glargine, everything has been implicated in the development of diabetes periodically. And even our professor Samji Mosa used to do in those days. So this modern synthetic insulin, which we are, they also has, by virtue of the different amino acid sequence, they may be prone for your malignancy. And the possibly due to mitogenic effects of insulin and insulin analogs, increased level of IGF-1 elaboration that can lead on to diabetes. And of course, the recent articles, they say the two things. One side of SGLT2 inhibitors, they have been found to produce more number of bladder cancer, and other side, the SGLT2 inhibitors protects from some of the cancer. How means? So association was not confirmed. The SGLT2 inhibitors may be useful for cancer therapy, as SGLT2 inhibitors are associated to increased tumor necrosis. So they shrink the tumor size and induced shrinkage, so it may be used. There was one set of authors. And of course, incretin-based therapies, they also have controversies, starting from DPP4 inhibitors and all the incretin-based therapies which have been implicated in the development of cancer. And this is a very common thing, the relationship between diabetes and cancer, hyperglycemia, hyperinsulinemia, insulin therapy, and genetic background, common risk factors, inflammatory markers, and pancreatic carcinoma. So these are the relative factors. And future development, this is a very important things. And these are the branched chain amino acid, leucine, isoleucine, and valine are essential amino acids both for the host and the tumor cells. It has been shown that elevated circulating BCAA levels are related to a number of conditions marked by insulin resistance. So in future, the BCAA levels estimation may be a marker for the malignancy. To conclude, there is a complicated association between diabetes mellitus and cancer. Risk of number of cancers and cancer mortality is increased in type 1 diabetes and type 2 diabetes. Some kind of cancer and cancer therapies are associated with increased risk of diabetes. And genetic factors, obesity, inflammation, oxidative stress, hyperglycemia, hyperinsulinemia, cancer therapies, insulin, and some other hypoglycemic drugs appear to play a role in crosstalk between diabetes and cancers. With this, I conclude my talk. Thank you for patient listening.
The topic is when to suspect secondary diabetes and how to treat them. Dr. Adeline Reena is an endocrinologist. She's from the family of MMC Diabetology, alumni, daughter of Dr. Arthur Asirvadam. She is, apart from that, I find her in every meeting in diabetes, metabolism, the recent times. Quite encouraging to see you. Over to you, ma.
Thank you, sir, for the kind introduction, and I thank the executive team of Tamil Nadu RSSDI and the organizing team of Track 2024 for giving me this opportunity to talk to you on a very interesting clinical topic, which is when to suspect secondary diabetes and how do we treat them. So I can assure you that I'm not going to show you any graphs, no p-values, no articles, no molecular genetics. So you can just relax and look at these clinical pictures and enjoy a clinical talk. So I'll walk you through what do we really mean when we say or use the term secondary diabetes. 5 clinical cases that we can come across in our clinical practice when we are managing patients with diabetes. When do we have to suspect a secondary cause of diabetes? Why should we even diagnose them when we know that anyway we are going to manage the diabetes? Is there any specific reason why we need to put our brains together to find out why this patient has got diabetes? And I will wrap it up with a summary slide. So what do we mean by secondary diabetes? Now, secondary diabetes is again diabetes, nothing extra, but it occurs as a consequence of another insult. It could be an underlying endocrine disease, it could be a genetic disorder, a metabolic disorder, or even simply a drug like corticosteroid that can put the patients at a higher risk of developing both prediabetes and diabetes. Now, what is so interesting and unique about this secondary diabetes? Now, we know that there are 2 critical components for diabetes, one being the beta cell secretory defect and 2 being the insulin resistance. Now, what you actually have is this extra, which is the increased counter-regulatory hormones or anti-insulin hormones that kind of mess up and complicate the entire pathophysiology of diabetes, making this form of diabetes difficult to diagnose, difficult to treat, and most importantly, what we can actually reassure the patients is that if you pick them up early, you can actually give them a better life with or without diabetes. Now, why do we have to really break our heads so much? We know that this is not a very common form of diabetes as we encounter with type 2 or even for that matter type 1. It just contributes to 2% of all the diabetes cases. Now, if you really look at the actual number, what we can be encountering, say for example, if you take 100 million cases of diabetes, you're going to have 20 lakhs of patients with secondary form of diabetes. So that makes it even important to identify and pick up these cases. And of course, they're quite common than being diagnosed. So this is the etiological classification of diabetes. I'm not going to go into the details, but what I'm trying to show you is that besides the type 1 and type 2 and the GDM that we actually deal with, we have such a large chunk of diabetes that occurred due to a secondary insult. So it could be the diseases of the exocrine pancreas, the endocrinological disorders, drugs, infections, autoimmunity, and more importantly, genetic syndromes. Now, beyond this, they all hide under the blanket or the under the cover of diabetes as a whole. So we need to really pick them up from the general pool of diabetes in order to make a good diagnosis and probably make the patient's life better as well. So let's move on to the clinical cases. The clinical case number 1 is about a 28-year-old gentleman who presented to us with new onset diabetes requiring very high doses of insulin. He also had headache, defective vision, change in the facial appearance for the last 6 months. He has a clinical OSA. On examination, he's normal weight, but you find signs of significant insulin resistance. He has a multinodular goiter, blood pressure slightly above normal, 140/90. Now, with this clinical background, this is how the patient looked. So the moment you look at this patient, of course, yes, he has acanthosis, but what you would see in a type 2 diabetes, you don't see here. You will see as disproportionately higher insulin resistance for a normal individual or an individual who is actually losing weight. Now, beyond this, you will see that he has some element of hypogonadism and also had a multinodular goiter. So, to watch closely, you will find that there is a prominence of the superior orbital fissure, a bulbous nose, thickened lips, significant pigmentation, and this is my colleague's hand compared to the patient's hand. You will find acral enlargement of this patient. So, this turned out to be a case of acromegaly presenting to you as just diabetes. Now, what happens in acromegaly? We know that the growth hormone is produced excessively from the anterior pituitary gland, secondary to a tumor, and that contributes more or probably fuels the entire glucose homeostasis or dyshomeostasis more. So, the most important thing beyond the beta cell defect and the insulin resistance, what happens in acromegaly is this growth hormone increases or exaggerates the lipolysis, contributing to excessive free fatty acids and therefore insulin resistance. And that is the reason why these kind of patients require high amounts of insulin to get the sugars under control. Now, the second thing what we need to remember is these are the patients who actually lose muscle more than fat, and that is the reason why they have insulin resistance both at the hepatic level as well as the peripheral level. So this is the slight difference that you would encounter in the glucose homeostasis in these patients with acromegaly. So what happened to the patient? We did an IGF-1, it turned out to be high. The growth hormone was unsuppressed following glucose. MRI showed a pituitary macroadenoma. We had put him on basal bolus insulin and added a metformin. He underwent a transnasal transphenodal excision of the tumor. Post-operatively, he was doing well, his symptoms got better, we were able to take him off insulin, but however, he did require metformin. He was left with a small residual tumor for which a radiotherapy was done, and patient is currently on octreotide. And unfortunately, as we know, that growth hormone excess can be associated with tumorigenesis, and this gentleman unfortunately had a papillary CA thyroid and also had to undergo a thyroidectomy for that. So the clue from this first case is whenever you have a young onset diabetes with uncontrolled, severe insulin resistance without much of obesity or even being on the overweight side and classic clinical features of acromegaly, think of a secondary cause. The clinical case number 2 is a 35-year-old lady, diabetes for 2 years. She had recurrent abscess. Every time she comes with an abscess, she even goes in for an impending DKA. And probing deeper, she gives a history of amenorrhea for 5 years, depression, primary infertility, and she was primarily referred to us for glycemic control for the fitness of IND. Now, this is how the patient looked. What you can see here is you will not see her as obese as you would probably look at a patient with type 2 diabetes. But if you closely look at her, she had significant pigmentation, hirsutism, facial puffiness, acanthosis. I'm not sure whether you can see the lentigines that is present in these patients. She had significant ecchymosis and striae, and this is nothing than a Cushing's syndrome where you have cortisol excess. Now, how does cortisol excess cause hyperglycemia and diabetes? Apart from the conventional ones, the most important thing that we need to remember is the visceral adiposity that contributes significantly to insulin resistance in these patients. And compared to acromegaly, here you have an exaggerated gluconeogenesis and fatty liver, even leading to fibrosis. Now, beyond that, you have a decreased incretin secretion and significant myopathy. So basically, these patients have muscle breakdown, and that is the reason why they have severe proximal muscle weakness, and that also contributes to diabetes in these patients. So we did a cortisol which was high, the overnight and the low dose dexamethasone suppression test was unsuppressed, ACTH high, and MRI picked up a pituitary microadenoma. Patient was put on basal bolus insulin, transnasal transphenodal surgery, and histopathology proved a pituitary adenoma which was having a positive IHC for ACTH. So fortunately, because it was a microadenoma, this patient did have a transient remission. The post-op cortisol was low. She was actually put on a supplemental hydrocortisone, and her diabetes did not remit, but it did was manageable with diet and metformin. So the clues from the case number 2 is amenorrhea, infertility. Whenever you have any gynecological problems, of course, we do have PCOS, which is more commonly associated with type 2 diabetes, but do keep in mind that you might be dealing with a patient with Cushing's syndrome. Case number 3 is a 20-year-old gentleman, again newly detected diabetes, lack of secondary sexual characteristics, a subtle intellectual disability, quite tallest in the family. The mother was so proud that the son is tallest in the family. Now, on examination, you can find that he has hypogonadism with testicular volume of just 3 ml, gynecomastia, and axillary hair 2 and pubic hair stage 3. So this is how the patient looked. You can see a centripetal obesity, gynecomastia, lack of secondary sexual characteristics. You will see a normal SPL. Remember that in hypogonadism, in hypogonadotropic hypogonadism, you may not see a normal SPL or stretched penile length. You will actually see microphallus. But in Klinefelter, you can actually see a normal phallus. And this gentleman had a testicular volume of 3 ml. So this turned out to be a Klinefelter syndrome. Now, we need to remember that hypogonadism, clinical hypogonadism can happen even in patients with type 2 diabetes, which can be much more common than a Klinefelter presenting with diabetes. Now, having said that, when you are really able to pick up these cases, we can actually treat them and reverse the diabetes. Now, this hypogonadism contributes significantly to the visceral adipose tissue because of lack of testosterone, and that contributes to the insulin resistance, metabolic syndrome, and the entire sequelae. So this young boy had a high FSH-LH and a low testosterone, clearly proving it to be a hypergonadotropic hypogonadism. His karyotype showed a mosaic form of Klinefelter syndrome. His A1C was 7.4, fasting of 146, postprandial of 210. He was started on testosterone and his diabetes is under remission even without requiring any medications. So the clues in this patient is hypogonadism, tall stature, intellectual disability, which should probably make us think of a possible hypogonadism contributing to diabetes. So the fourth case is a 45-year-old lady who was picked up in a thyroid camp who just came for a follow-up of total thyroidectomy, came with a classic paroxysm symptoms of palpitation and high blood pressure remaining very high, resistant and refractory, a random blood sugar in the camp comes back as high. So if you look at this lady's back, this is something called as a cutaneous lichen amyloidosis, which is a classic marker of the multiple endocrine neoplasia type 2A syndrome, which is associated with medullary thyroid carcinoma, pheochromocytoma, and hyperparathyroidism. So this lady probably had diabetes, possibly due to the catecholamine release. Now catecholamines, as we know, has a pleiotropic effects on all possible systems. So you will have an impact of catecholamine on every other system. But what really makes these patients evident from other patients is you will have a fluctuating hyperglycemia and hypoglycemia. A sudden spurt of hyperglycemia with DKA followed by a sudden drop in blood sugar of hypoglycemia. So that is something which is very classical of these patients who have catecholamine excess. So again, biochemically we could prove hyperglycemia and diabetes. Patient had an adrenal mass, underwent surgery after appropriate alpha-beta blockade, and her hypertension was definitely controlled with one antihypertensive, but her diabetes was much better. So whenever you have paroxysms of symptoms, think of pheochromocytoma. The fifth case is a patient who came to us with thyrotoxicosis, thyrotoxic storm in fact, and this patient actually had orbitopathy and dermopathy, as you can clearly see here. Clearly thyrotoxicosis, TRAB antibody, TSH receptor antibody was strongly positive. She was treated with antithyroid drugs, methylprednisolone, which kind of worsened the hyperglycemia, which was given primarily for the active eye disease. But of course, on long-term follow-up, her diabetes underwent remission. So whenever you have thyrotoxicosis, which is one among the commonest situations that you would come across, can contribute to hyperglycemia and diabetes, and that definitely needs to be picked up, because if you are really looking at doing something good for the patient, if you pick up thyrotoxicosis and treat that patient, that's going to reward much higher. So thyroid hormone again has extensive action on all systems. More importantly, it can degrade your insulin quite rapidly. So therefore, they need more insulin than you would rather really look at. Sometimes we do look at calculating insulin based on body weight. These patients lose significant weight, and so if you calculate the insulin dose based on the body weight, you might actually end up giving them less. So have in mind that thyrotoxicosis needs more insulin because of excessive metabolism and degradation. So when do you suspect? Whenever you have young onset diabetes with multiple comorbidities, when you have reproductive system involved, when you have significant weight loss with hyperandrogenic, adrenogenic symptoms, high insulin requirement, fluctuating insulin requirement, early end organ damage, no significant family history. We will not find anybody without a family history of diabetes. If you find so, have an eye that this patient might have secondary diabetes, and of course, drugs come into play. Clinical examination, all the features that we had discussed until now, keep in mind when you're really examining the patient with diabetes. Now, when you suspect genetic syndromes, whenever you have a combo of diabetes along with an endocrine manifestation, be it short stature or hypogonadism, tall stature, hypogonadism, deafness, diabetes, all these things should prompt us to think of a genetic syndrome that is contributing to diabetes. Now, why should we really break our heads? Anyway, we are going to give them the same insulin, same metformin. What really are we going to achieve by branding these patients as this form of diabetes or this is causing diabetes? Now, the most important thing is we can achieve significant amount of cure or diabetes remission in these patients. The prevention of progression from pre-diabetes to diabetes can be prevented if we are really dealing with the root cause. They have a high risk of mortality and complication, especially diabetic ketoacidosis. And of course, as a treating physician, we need to identify and pick up why this patient has developed this disease and probably treat them also. So my last slide would be to talk about diabetes remission. Now, all these endocrinological disorders can actually offer remission, provided we are able to give a complete cure of the endocrinological problem. Of course, in case of pituitary macroadenomas, the remission rates might be less, but if you are picking them up early, if you are going to treat them for the microadenoma, the prognosis is much better. So to summarize my talk, the endocrine disorders causing diabetes are not uncommon. You can always have coexisting diabetes and endocrinological problems. clinical clues, even until today, remain the key for making the diagnosis. Of course, you can look at investigations, provided you have a good pre-test probability for these patients. You can aim at diabetes remissions, provided we are identifying them and picking them up early. And last but not the least, the most important thing is keeping not just your eyes, your minds, your ears open for an additional endocrine surprise while managing patients with diabetes can really help us to pick up more cases and treat them well as well. So thank you very much for your patience listening. And
Thank you, Dr. Adeline. You are living more than your expectation. You are speaking very faster than your father. And we are very happy to see that. Arthur will talk very slowly, but you are very fast and finished in time. And nicely talked about the remission or curable or reversible diabetes. Really, the case studies were really good. Please take your seat, and we will. Next speaker will be Dr. Pushpa Saravanan, Associate Professor of Diabetology, Madras Medical College, member of our MMCDA alumni, and very, very active personality, very, very friendly and helpful. Over to Dr. Pushpa to talk about understanding and preventing hypoglycemia in diabetes.
So good evening, everyone. And thank you, sir. Thank you, chairpersons. And thank you, organizing committee and the scientific committee for giving me yet another chance to talk among the elite. And we will talk of hypoglycemia in diabetes. How to prevent it is the most important part. And usually when we talk of hypoglycemia, it is talked under the acute complications of diabetes, which should not be so, because it is not a complication of diabetes. It's something iatrogenic, which we create. So it is an adverse effect of the treatment of diabetes. So that is what we should always remember. And we should be very careful when we are treating the patients with diabetes. And this is the reason why, because of the hypoglycemia associated with the drugs which we use to treat diabetes, we cannot keep the level of HbA1c to as normal as possible. That's why the cutoff is only, we expect less than 7%. We don't say that bring it to less than 5.6%. Because we are scared of hypoglycemia, and no such drug or regimen is available where we could write it without fear that the patient will not develop hypoglycemia. Drugs like metformin or gliptins or SGLT2 inhibitors, anything given as a monotherapy also can cause hypoglycemia in any patient. So the ADA defines hypoglycemia as any episode of abnormally low blood sugar which exposes the individual to potential harm. And biochemically, for patients with diabetes, it is a plasma glucose concentration of less than 70 milligram with or without signs and symptoms of hypoglycemia clinically. And otherwise, we define it with Whipple's triad, where we see if the blood sugar is less than 54 milligram per deciliter, and the patient has symptoms of hypoglycemia, which improve after giving adequate glucose. So what are the various causes of hypoglycemia? Can be divided into fasting and postprandial. And fasting, the most important cause of hypoglycemia is iatrogenic because of the insulin and oral drugs. Hepatic and renal failure, where the clearance of insulin and the drugs is reduced, will again cause hypoglycemia. Tumors like insulinoma, congenital enzyme deficiency like G6PD and liver phosphorylase are all important causes of hypoglycemia in the fasting state. Postprandial, again, drugs can always be a cause of postprandial, because if given in high doses, they can cause hypoglycemia. Then they can be idiopathic or functional, reactive hypoglycemia, and elementary hypoglycemia. Precipitating factors for hypoglycemia is, first, very important, is an inadequate carbohydrate intake, which means it can be either the patient is not taking adequate diet, missing the meal, or delayed meals. This delayed meals and missing the meals is the most important cause of hypoglycemia. So every time we advise the patient to take any oral drugs or insulin, we have to tell them to take their food in time. Many a number of times we see patients, they'll take their drug and night dose of insulin or oral drugs they will take, and then the breakfast will be very delayed. They will be eating their breakfast only at 11 o'clock, 12 o'clock, and they will always complain of morning hypoglycemia. So it is not because of the drugs per se, but because the patient is not taking their food in time. Then again, the dose errors or deliberate increased dose of insulin can be a cause by mistake or deliberately. Then increased bioavailability of insulin. So conditions where we exercise, where the where the glucose utilization is more. So conditions like exercise. Then the site of injection. If the insulin is given intramuscularly, so it will act fast, it will be utilized fast. So the levels of insulin will be higher and it will reduce the blood sugars faster. And then again, renal and liver failure, where the clearance of insulin is slowed. Then increased sensitivity. So whenever patient has a drastic weight loss within a short duration of time, they are more prone to develop hypoglycemia. Then excessive physical training, postpartum periods, these are the situations where we expect hypoglycemia can occur. And other things like alcohol, very important cause of precipitation of hypoglycemia, because if people don't take anything along with alcohol, alcohol is poor calories, so they may develop hypoglycemia if they're continuing taking their medications, some drugs, and gastric autonomic neuropathy. Now, hypoglycemia has been classified into 3 levels as per ADA. So level 1 is what we say in diabetes, less than 70 milligram. This is a hypoglycemia alert. So once it is coming to 70 or below, we should reduce the dosage, and we should just see if the patient is having any other problem not taking in time. We have to evaluate the patient. Level 2, clinically important, where the glucose level goes to less than 54 milligram. And in clinical trials, this is the level at which hypoglycemia should be reported. And level 3 is severe. Here, the patient goes into severe cognitive impairment, which requires external assistance for recovery. So I'll discuss a few cases. So first is a case of 17 years boy who has type 1 diabetes for 7 years, who was regular with the follow-up, but had on a regular follow-up visit, he complained of early morning hunger. And he was on 40 units insulin in the morning and 40 at night. And you can see the blood sugar values. So after this 40 morning, 40 night, though he had some complaints of early morning hunger, the night dose of insulin was reduced, and he was advised to come with his glycemic profile. So this is what we saw after the glycemic profile. We can very well see here that the 3 a.m. blood sugar, you can see the 3 a.m. blood sugar is just 34 milligram per deciliter, and the postprandial and pre-lunch sugars are on the higher side. So this is a typical case of Somogyi phenomenon. So here again, another patient's CGM. So here again you can see, okay, it's not, okay. So you can see every time there's a hypoglycemia, the patient has a hypoglycemia followed by a spike in the blood glucose. And when you look at this, this patient is having a lot of time in the day he's spending in hypoglycemia. So this child was on insulin pump. So afterwards we made him change the settings, and his hypoglycemia events reduced. So there is another phenomenon called dawn phenomenon, which is, again, the patient will have early morning hyperglycemia, but this is a physiological phenomena, which is because of increased counter hormones, especially the steroids increase in the secretion in the morning, whereas Somogyi phenomena is pathological phenomena. It is a post-hypoglycemia. It can occur at any time of the day. HbA1c may be controlled, and the treatment for Somogyi is to reduce the preceding insulin dose. Whereas for dawn phenomena, usually there will be no preceding hypoglycemia, it's just hyperglycemia. So it is because of the increased cortisol secretion from the body itself, and here the HbA1c will be elevated, and the treatment will be to increase the night dose of insulin to match the blood sugar spike in the morning. So when we talk of hypoglycemia, we should understand about asymptomatic hypoglycemia, which is presence of biochemically low glucose without any symptoms. So we come across a lot of patients with this kind of hypoglycemia, and most of the time it is nocturnal, and it is only recognized with the help of blood glucose measurement, and the treatment is adjustment of therapy, and advise that they should take their food in the right time. Now here we will talk of the how the body responds to hypoglycemia. So whenever the blood sugar goes down, okay, so every time the blood sugar goes down, the beta cell insulin secretion reduces, And this reduction in insulin causes increased secretion of glucagon from the alpha cells. From the brain, the sympathetic outflow increases, which leads to increase in norepinephrine and acetylcholine secretion, which is the cause for the various symptoms associated with hypoglycemia. And as we go further down, the neurogenic symptoms also develop as it lowers more and more. So what is the body's response? When in a normal person, when the blood sugars are around 80 to 85, the first response to hypoglycemia is endogenous insulin secretion is suppressed. When it goes down to 70 to 75, the counter hormone secretion starts reducing. So the glucagon, cortisol, every secretion will start reducing. From 50 to 55 milligram onwards, the autonomic warning symptoms of palpitation, tremors will occur, and less than 50 usually the glycopenia sets in. This is what happens in non-diabetic individuals. So these are the various symptoms of hypoglycemia, which I had already told. So neuroglycopenic symptoms are important, where the patient will be coming in a state of confusion, drowsiness, may have odd behavior, speech difficulty. They may even come with hemiparesis or circumoral paresthesia, focal neurological sign. And non-specific symptoms like headache, nausea, weakness, and blurred vision can also be attributed to hypoglycemia. So we come to my second case, a 70 years old type 2 patient, 10 years of diabetes on glycoside and metformin, brought into the ER in unconscious state with history of fall in the washroom. Vitals was stable, CBG was 38 with a laceration over the occipital region. And he was treated with IV dextrose, and after clinical improvement, CT brain was performed, which showed occipital bone fracture and traumatic brain injury with subarachnoid hemorrhage. So this is very important in the sense, this is a case where the patient didn't have the symptoms of hypoglycemia and straight away went into unconsciousness, and this could be a case of impaired awareness of hypoglycemia, and which occurs because of autonomic failure. And here the autonomic symptoms of hypoglycemia are lost, and straight away patient goes into neuroglycopenic symptoms. So what are the possible causes of IAH? Long duration of diabetes. When we try very tight metabolic control, recurrent hypoglycemia may cause hypoglycemic unawareness or impaired awareness of hypoglycemia, what it is called now. It is more common in elderly and children and in people who are taking alcohol and drugs like beta blockers. Now we have a vicious cycle of hypoglycemia. So this is how, if there is chronic hypoglycemia, there will be decreased physiological response to hypo, which will cause decreased awareness of hypo, increased vulnerability, and again more and more hypo. So this goes on and on. And and then there is another terminology called hypoglycemia associated autonomic failure. So it is very important that if we need glucagon secretion, insulin is the one which will cause increase in glucagon secretion. So in patients with type 1 diabetes and long duration of diabetes, the insulin secretion is very poor or absolutely nil. So in such patients, when there is no insulin, so glucagon increase is not there, which will cause hypoglycemia, and there will be attenuated sympathetic adrenal response to hypoglycemia, which is half, and these patients may go in for recurrent hypoglycemia. Now in this patient, 70 years old, we were talking about what are the problems. He's an elderly and on sulfonylureas with impaired awareness of hypoglycemia. So we have to take a detailed history. We have to stop the diabetes medication because blood sugars were around 38, and we have to give proper education to the patient, make them understand the problem. We have to observe for recurrence of hypoglycemia. We can write drugs which have lesser propensity for hypoglycemia. And we have to relax the glycemic target in such patients. And one more important is, any patient who comes with hypoglycemia, unconsciousness or altered sensorium, please check them properly. If there is an injury, we should take up a CT scan. We may diagnose other problems. So third patient is a security guard with 20 years of type 1 diabetes, fluctuating blood sugars, A1C elevated, ECG TROP-T normal because patient had come with profuse sweating and inadequate control. So this was the picture of the patient taken. So here we can see lipohypertrophy, which is because of continuously using the insulin at the same site. And she was working as a security guard, so she didn't have an adequate place to inject insulin. So other things like exercise and hypo, very important. So Every time patient goes for an exercise, they should either take a snack or reduce the dose of insulin. And insulin should not be injected into the exercising limb, the limb which you're going to use during exercise, and additional snacks to be taken. Alcohol I've already talked about, factitious I could skip. So hypoglycemia is not without any harm. It is not just reduction in blood sugar which can be treated. We have a lot of problems which can occur. Patient may develop TIA, stroke, angina, death or accidents, worsening of neuropathy. In children, it can, in mothers who develop hypoglycemia, they can have fetal distress and vitreous hemorrhage in patients who are having proliferative retinopathy. And hypoglycemia causes increased thrombosis, inflammation, endothelial dysfunction, which will lead to atherothrombosis. Arrhythmias are cause of sudden cardiac death. And prevention is do not delay or skip or reduce the food intake, carbohydrate snack before exercise, avoid insulin injection in exercising limb, periodic monitoring, and carrying a diabetic identity card. So best is oral glucose in a conscious person, 20 to 30, or sucrose, or a meal if patient is about to have a meal. In unconscious, IV glucose, or we can even use subcutaneous or IM glucagon. In children and adolescents, the threshold of symptom will depend on the glycemic levels. Neuroglycopenic symptoms are more common, and counter-regulatory hormone response will be at a higher plasma level, and they need psychological and social support. In children, it is the most important hypoglycemia. It is anxiety to the parents because they are taking care of the children. So we have to teach them well about hypoglycemia. And technology, so SMPG, CGM, in advanced pumps, they all help in reducing the incidence of hypoglycemia. And in future, if we have bihormonal pumps, pancreas, islet cell transplant, or stem cell and gene therapy, these may be helpful. They will be really helpful in stopping the problem of hypoglycemia. Thank you for being so patient.
Thank you, Dr. Pushpa, for a professorial talk. She's an associate professor, regular teacher. You proved that with the case studies. And now the three talks are open for the questions. First talk by Dr. Periyandava, diabetes and cancer. And second about talk by Dr. Adeline Rina, the secondary diabetes, and third, hypoglycemia. So we are running behind schedule. So I will allow 3 questions in this session, sir, and we'll go to the next session.
Dr. Rina, what about paraneoplastic syndrome producing diabetes, especially in renal cancer?
Come there to the front.
What's your opinion?
Rina, you can come to the stage also.
So actually, paraneoplastic syndromes most often present with hypoglycemia. And only when they have glucagon excess, they actually present with hyperglycemia.
It can present with
It
diabetes.
can present, yes,
Yeah,
in a very
that's why
subset of
when
patients.
there is renal cancer, it can present. Will you call a secondary or primary?
Renal cancers, unless they are associated with von Hippel-Lindau syndrome, usually the clear cell carcinomas are not generally associated with secondary as a secondary cause of diabetes.
Yeah, second question is to Dr. Pushpa. Hypoglycemia in a diabetic, suppose we are treating the patient who is well controlled or not well controlled. After some time, it gets controlled with the same medication. And you have to suspect renal failure in these patients. So it is mandatory to do renal parameters whenever the blood glucose is getting controlled with the same medication, or sometimes patient goes for hypoglycemia.
Yes, exactly, sir. So every time a patient goes in for hypoglycemia, those who have long standard duration of diabetes. Yes, sir. That's what exactly, sir. We have to look for. We have to evaluate these patients.
The question and answered.
Yes, sir.
Professor has answered. There is no need to explain now. Any other? Yes, Velu sir.
To Dr. Pushpa, have you ever come across hypoglycemia due to telmisartan? In your
No.
correct. Yes. That were doctor. I have evaluated completely. In fact, I have reduced the dose, which was suggested by cardiologist. After reducing the dose, he became normal. One. Second thing is clopidogrel-induced hypoglycemia.
Velu sir, do we have any data on these?
No, only one. It is a case report.
It's a case
so
report.
I am asking whether she has also come on the same way.
Okay, fine.
Dr. Pushpa, Madam, beautiful presentation. Have you come across any case of gliptin, sitagliptin, in association with pantoprazole? hypoglycemia. Some patients,
Sitagliptin hypoglycemia we have seen, but with pantoprazole we do not know, because many patients are taking the drugs, we do not know if they're on pantoprazole because they take it over the counter. So it may be, we'll see in future. We'll ask that also.
in our areas, village side, when the patient is taking basal bolus insulin, by mistake what they do is instead of basal insulin at night, they do this bolus insulin. Main cause, we have to educate, as you rightly pointed out, education is very, very important. You have to educate the patient and the family members, even our staff members. One. Second thing is reuse of needles, something it causes. As you rightly pointed out, the lipo something it causes. Some patients, old age patients, double dosing of insulin it causes in our areas. Thank you.
Sir, it is common everywhere, not your area alone. Even in educated people, it happens.
Minute. Dr. Adeline, now you have been put a slide about these lichen amyloid, which is a marker. But by and large, in the practice, in diabetes, many times we see in diabetic patients, there's amyloid deposition. How do we typically differentiate that lichen amyloid from the routine pigmentation? Because we quite commonly come across pigmentation in the legs.
The scleroderma of Wuschke, which is traditionally taught, is very common in type 2 diabetes. But usually these patients do not have symptoms unless there is some secondary infection. But this CLA or the cutaneous lichen amyloidosis, they can have itching and they can have secondary infection. But it's very difficult to differentiate. Only a skin biopsy can actually give you a clear diagnosis. But in the context of the other problems, we picked up.
Yeah, thank you, Dr. Adeline. And Periyandavar, are you available? You've been talking about the diabetes and cancer, and you said the biguanides had a higher risk of cancer, but to our understanding, the metformin, the data from metformin seems to have an anti-cancerous effect.
I have mentioned about I have mentioned about mainly the anti-cancer effect.
But by
of
and large,
metformin.
many a time, is it because some drugs are reducing this cancer and increasing that cancer?
Yeah, that was
and you put a big
conflicting. So
list.
only I have referred to so many articles.
That's what my question is.
Yeah.
What is going to be a practically, because you listed almost the entire drugs. These drugs causes 2, and this causes lesser incidence of that cancer. So what do you want to, as a clinical perspective, as the bench to bedside, what do you want to tell the delegates who come here? Screening for malignancy cancer has to be kept in mind. That's one, no?
Yeah. First thing is, diabetes per se is a carcinogenic, number one. Through insulin resistance, that pathway I have mentioned. Second thing is, the interrelations between diabetes and cancer I have mentioned, and the contradicting papers. So one paper saying I told you the SGLT2 inhibitors, one paper says bladder carcinoma is more, and the subsequent paper says it's a beneficial effect on cancer.
I think probably we need more time and more data, robust data to categorically say these drugs causes a malignancy. You say diabetes causes cancer. Again, we are coming to say anti-diabetic drugs causing cancers. Probably this might be not a mere association. Probably we need a more robust and long-term follow-up studies to categorically say.
More documentation. We have more number of patients.
Thank you, Pari. Thanks for all the... Paneer.
Regarding pioglitazone, after introduction of 10 years after introduction, they told bladder cancer. Now 2013 to now 2025.
Yes.
For the past 13 years, we have not come across that much of cancer incidence, bladder cancer
Yes,
incidence.
yes. Okay.
Similarly, Lantus and breast cancer also. We don't come across.
Paneer, we are just closing the...
Follow-up, long
Yeah,
follow-up.
thank you. Thank
Sir,
you.
with regards to that, I have one point, sir.
Yeah, just
either the glucotoxicity itself can feed the cancer cells. That is one possibility of association between diabetes and cancer. The other one, there are some drugs which act like giving fasting to the cells and promoting apoptosis and other stuffs. So maybe due to mTOR pathway also, they can promote anti-cancerous actions, and could be that be the reason, maybe not proved so.
Yeah, thank you. All the three speakers. Give a big round of applause to the speakers.